Hello dear students. So we can start the session and starting with pharmacology. So the very first question goes like this, like after which phase of clinical trial a new drug is introduced into the market. We know that there are 4 phases of a clinical trial. So after which phase the drug is introduced into the market? So the answer is phase 3. Now let us discuss the phases as such. Now phase 1. Now what is phase 1? Phase 1 is about the human safety. So whatever the drug we are planning to introduce into the market, it should be safer. Right? So it's about human safety. In phase 2, once we are very sure that the drug which is under consideration is safer for the humans, then we move on to phase 2, and here we try to evaluate the drug in terms of efficacy, potency, and all other drug related studies. So everything related to the drug, so that we can have the best and optimum effect, that is studied in phase 2. Now in phase 3, yes, efficacy, right Shubham? In phase 3, the drug which is under consideration, we will do therapeutic comparison, right? So we will do comparison. It means, yes, compare. So whatever the drug we are planning to introduce in the market, we have to compare that particular drug with the already available options in the market. So that is therapeutic comparison, and we just want to make sure that whatever the drug we are planning to introduce into the market, it has to be superior to the already available option. So in phase 3, we will go for comparison. And once we are sure that whatever the drug we use, it is better than the already available option in the market, we will release the drug into the market. The drug is released, introduced, clear? Now phase 4 is post marketing surveillance. Once the drug is in the market, we will have tie-up with the physicians who will prescribe this drug to their patients, and then we will study the long-term side effects, or we will study the drug interactions with other drugs. If this particular drug is given with some other drug simultaneously, what kind of interaction will come out? That is studied in, right? So in phase 3, we introduce, after the completion of the phase, we will introduce the drug into the, right? So phase 1, phase 2, phase 4, and phase 4 is a very long-term study. The doctors will prescribe the drug to the patients, and then we will gather up the data about the drug side effects and all. Right? So the better answer is phase. Yeah. So phase 1 is about drug safety, and of course here we try the drug on, right? So we'll give the drug to normal, you can say healthy volunteers, and this is given under, you can say, ICU setup, because we don't know what kind of effects might come. So we should have all those facilities readily available in case if there is some life threatening side effect. So phase 1 is about checking the drug safety, and that is the trial on normal humans. Once this is done, we'll go to the phase 2, which is done on small segment of patient, and we do all drug related studies like in what dose, frequency the drug will be more beneficial. Right? And in phase 3, we will compare it with the already available in the market. And once we are confirmed that yes, this will be definitely a better option for condition for being marketed. So after that, we can release it into the market. And phase 4 is long-term studies. Yes, one is saying like COVID vaccine. So that is long-term study. So introduction of phase. Yeah. Now, high volume of distribution of a drug depends on the lipid solubility. So more lipid soluble the drug, more is the volume of distribution. Right? So that depends on lipid solubility. Now, what adverse effect of lithium can be on long-term administration, except so not a feature of or not a side effect of lithium therapy after 1 year? The answer is yes, Rubik, you are right. The answer is tardive dyskinesia. We see tremors, we see even diabetes insipidus. So tardive dyskinesia has nothing to do with lithium therapy. Now, which of the following drug shows zero order kinetics? Now, before that, we should understand what is zero order kinetics, first order kinetics. In zero order kinetics, there is excretion of the drug, but there is a fixed amount drug is, so there is a fixed amount of drug is excreted, and suppose if you have given 100 mg of drug, and if it 25 milligram is excreted, so every time 25 milligram will be excreted. So 75 and again 25, right? So this is constant amount is excreted. Clear? So this is zero order kinetics. Then the other pattern is the first order kinetics. Another one is the first order kinetics. Here a constant fraction is excreted. Here a constant fraction, it can be say 20% or 30%, whatever. So a constant fraction will be excreted in first order kinetics, and a constant value or constant amount will be excreted in zero order kinetics. So this is the basic difference between the two. And if you look at the curve, so for zero order kinetics, it is a straight line. For zero order, it is a straight line, and for first order, it is a curved line. This first, this is here. So in zero order, there is a constant amount which is excreted. In first order, there is a constant fraction or a constant proportion of the drug eliminated per unit of time. So zero order is shown by phenytoin. Yes, you can have your own mnemonics, no problem, but that is the basic concept. Amount zero order and in. Clear? Now, which of the following drug requires therapeutic drug monitoring? It means the optimum effect exerted within a specific plasma range. Right? If the value is below that range, optimal effect, and if the value is above that range, there will be toxicity, you can say. So the optimum value will produce optimum results, and therefore we have to monitor that the drug concentration in the plasma is within that particular range. So for that we need to measure the amount of drug in the blood, and that is known as therapeutic drug monitoring. Now this is seen in cases of phenytoin, but you should remember at least two examples. One is lithium, of course, and second is hydroxy. Please remember at least two examples, lithium and hydroxy. We have to check their plasma values. So this is the concept of therapeutic drug monitoring. Now, next question. No need to do for isonia. The alcoholic male patient, he is taking metronidazole and now developed flushing episode. What is this? Very good. So this is disulfiram reaction. Now, what actually is this drug disulfiram? Any idea what disulfiram? Now, this disulfiram is given for de-addiction of alcoholism. Right? So, de-addiction of alcoholism, and if patient is taking disulfiram and if we consume alcohol also at the same time, there will be severe reaction in the form of flushing. So, if the person is on disulfiram, he will avoid taking alcohol because of these reactions, which is actually known as the disulfiram reaction. So, sometimes same kind of effect can be shown by some other drug as well, like metronidazole. So, this is actually the disulfiram. Then coming to the next question, ACE inhibitors are not used in. Yes, ACE inhibitor is not used in. To answer this question, yes, Raghu, you are right. Yes. To answer this question, you have to understand that one of the major side effect of ACE inhibitors is hyper. Right? So it is a side effect of ACE inhibitors. So there is no point in giving ACE inhibitors in a patient who is already having hyperkalemia. Right? Otherwise, this will lead to fatal hyperkalemia. And based on the same concept, it is also said that never combine ACE inhibitor with ACE inhibitor with any other drug which is also causing hyperkalemia. because if you give these kind of drug which is causing hyperkalemia, there will be fatal hyper. And one of the classical example is spironolactone. Never give ACE inhibitor with spironolactone, because spironolactone is also a potassium sparing diuretic, so there will be fatal hyperkalemia. So please remember, one of the complication of ACE inhibitor is hyperkalemia. There is no point in giving ACE inhibitor to a patient with hyperkalemia. This is a good question. Which of the following is valuable in obtaining variation in sensitivity of response to different doses of drug in different individuals? So what we will prefer? Yes, this is dose response curve. Yes, DRC, very good. Dose response curve. And if you look at the dose response curve, you will find two terms. One is the potency. One term is potency, and another term is efficacy. There are two terms which we discuss in dose curve. One is potency and another is efficacy. Now, potency is the amount of drug required to produce certain response. Okay. So, it is the amount of drug which is required to produce certain desired response. Suppose if you see in the graph, if you compare the drug A and B and the A and C, sorry, it's better to compare A and C. So compare, no, this is the desired response. Suppose this is the response we want to expect, we are expecting. So this much amount of drug A is required to give the response, whereas you need a little more amount of drug of C to get this response. So it means A is more potent than C, because the amount of response which is achieved by C, the same amount can be achieved by A in a very less quantity of drug, right? So the amount of drug required to produce certain response, that is known as potency. And in this case, you can say that A is more potent drug C. Clear? So whatever amount of drug or a particular effect, that will decide whether it is potent, more potent or less potent. Now another term is efficacy. Efficacy means the maximal response a drug will produce in a given, right? So if you are giving same dose, and then you will look at the height of the curve, so that is known as efficacy. Yeah. So maximum response, efficacy, and amount of drug or the dose of drug get that particular response is potent. Please remember this concept, because many times we have a graph based question and the question revolves around these 2 points only: which drug is more potent, efficacious. So that is the concept. Clear? And here we don't have actually anything related to efficacy, but if I can draw, I draw a drug, say this is drug C and drug D, then you can say drug C is more efficacious than drug. Okay. So this is how we describe potency. Clear? Now B cannot be taken here because B is not going up to the desired response. So better comparison can, in terms of potency, can be done between A and C. So for potency, the higher part has to be same, And for efficacy, the lower part, the lower point or the concentration of the drug has to be. Yeah. Chalo, next question. A patient has pain related to gout and this pain subsided. Now we want to excrete, we want to promote the excretion of uric acid. Which drug? Yes, yes, you are absolutely right. This is probenecid. So this is uric drug, means it will promote excretion of uric. Fine. So this is probenecid. Remember, allopurinol prevents formation of uric by inhibiting oxidation. Okay? Uricosuric. Right. Which of the following diuretic inhibits carbonic anhydrase enzyme? Acetazolamide, yes, correct. Acetazolamide, and if you have just a basic classification of the diuretics, the one which you should know at least, one is the osmotic diuretic, which is mannitol. The second one, the carbonic anhydrase inhibitor, that is acetazolamide. The third one, or most important one, in fact, these are the loop diuretics, high ceiling diuretics, especially furosemide. Fourth one is the thiazide group, includes hydrochlorothiazide, and potassium sparing is spironolactone, which opposes the action of aldosterone. So remember at least these five groups. Now, next question. A known case of hypertension was on some antihypertensive drug, but during the course of the treatment, he developed cough. Which drug can? I think this is a very basic question. So this is dry cough, very common side effect of ACE inhibitor. Yeah, dry cough. Everyone is right. Now, patient of schizophrenia is responding well to haloperidol, but later on he developed symptoms of Parkinsonism, that is antipsychotic extrapyramidal side effects because of antipsychotics. Now, which drug should be given to control this complication? Very good, Raghu. Especially in cases of drug induced Parkinsonism, you have to give anticholinergic, that is benchtropine or benhexo. Very good. Perfect. Next question. Patient has morning stiffness, joints, and the treating doctor plan to start the disease modifying agents in rheumatic disease. Which one requires fundus examination and regular monitoring of visual acuity if started? Yes, this is hydroxychloroquine, right? Hydroxychloroquine. It can cause bull's eye maculopathy. Okay. So with the Pratusha, you are right. So this is bull's eye maculopathy for hydroxychloroquine, and the possibility is even more with chloroquine as compared to hydroxychloroquine. So fundus examination, visual acuity has to be monitored while we are giving hydroxychloroquine. Now, which of the following anti-asthmatic drug does not cause bronchodilation? Which of the following anti-asthmatic does not cause bronchodilation? And what is the answer? Yes, hydrocortisone, because this is steroid and these are anti-inflammatory, has to do nothing with bronchodilation. So steroid. And if you take the classification for the bronchodilators, you can have anticholinergic, of course, principally pratropium or tiotropium. Then you can have sympathetomimetics like salbutamol, terbutaline, okay, and then you can have methylxanthine, namely theophylline or inophylline. Post-COVID, patient develops tingling sensation, and as per him, that he took this of medicine during COVID is this is excess of vitamin 6 pyridoxine. Yeah, that can lead to absolutely right. So this is tingling sensation because of excess of pyridoxine. Next question. A pregnant lady with Vivax malaria, which drug is preferred in this case? What can be given? Yes, very good. Quinine can be given into a pregnant lady with Vivax malaria. Yes, right. Now, mechanism of action of furosemide is eye sealing or loop diuretics. Yes, and these are also known as loop diuretics because they act in loop of Henle, where they inhibit enzyme, the symporter, sodium potassium chloride symporter in the loop of Henle. So this is the site of action of loop diuretics, where they inhibit sodium potassium chloride transport. Izides, they act at the distal converted tubule, where they inhibit the sodium chloride transporter. Then the potassium spironolactone diuretics, they act on the DCT and they inhibit the action of aldosterone. These are the three important class of diuretics and their site of action. So furosemide, also known as loop diuretics because they act at the loop of Henle. Now, a patient presented with resting tremor, rigidity and bradykinesia. Which of the drug will not be helpful in managing this case? Yes. So the classical this presentation is Parkinson's disease. Right? So this is Parkinson disease, and there is no role of giving rivastigmine because rivastigmine is used in Alzheimer's. And it acts by inhibiting which enzyme? Acetylcholinesterase enzyme. And this is the enzyme which actually degrades. So in one way it is, yes, donepezil galantamine can also be used for Alzheimer's. So this makes sure that whatever the functioning neurons are there, at least the acetylcholine which is secreted is preserved. It is not destroyed by acetylcholine. Right? So rivastigmine has nothing to do with Parkinson disease. Now imipenem is co-administered with cilastatin. Why? Why imipenem is given with cilastatin and not alone? Actually, what happens? imipenem destroyed by dehydrogenase. So the degradation is done by dehydropeptidase. So what we want to do, we want to give a drug which will inhibit this enzyme. For that we give cilastatin. Right? So cilastatin will inhibit dehydropeptides and will make sure that imipenem is there in the sufficient quantity so as to bring about the pharmacological effects. Right? So that's why instead of plain imipenem, we prefer imipenem plus in combination. Very good. That is the reason why we add cilastatin to imipenem. The answer is cilastatin inhibits an enzyme in the kidney which degrades imipenem. Here, next question. A newborn is born with cleft lip, cleft palate is important here, ESD, and there is history of some drug intake by mother. What drug it can be? Yes, you are right, absolutely right. It is isotretinoin, and here the classical is cleft palate, classical. Apart from this, there can be thymic aplasia. Also, there can be neural tube. Cleft palate is classical for as a teratogenic effect of isotretinoin. Therefore, whenever we are using isotretinoin in nodulocystic acne, always rule out pregnancy. So, always rule out pregnancy. Very important. Which drug is least effective in a male patient who is having burning micturition and there is large number of pus cells on urinary examination? Anyone? What is the clinical condition? What is the clinical condition? Clinical condition is UTI. Right? So this is urinary tract infection, and there is dysuria, and we can see large number of pulse cells. So here the treatment actually is urinary antiseptics here, and moxifloxacin is not a member of this category. Right? So we can give nitrofurantoin, nalidixic acid, ciprofloxacin. So urinary antiseptics has to be given. For bipolar disorder, what needs to be given? For bipolar disorder, this is lithium for bipolar. The drug of, yes, we can use lithium with antipsychotics, but theoretically, if there is a question, you have to mark lithium. Need to give antipsychotics in combination as well. A patient was on anti-cancer chemotherapy, but later on he developed fever, sore throat, and presentation suggestive of severe infection. And when we did TLC, we found that TLC was only 2000 meter. So what drug can be given now? Yes, this is filgrastim. So you can see this is all of neutropenia. Your infection, this is of neutropenia. You can give filgrastim. A boy had generalized tonic-clonic seizures for 8 minutes. Airway is okay, but the child is continuing to have seizure. What should be the initial step to control seizures? Here, if child is having continued seizure activity, some book says that even like for more than 5 minutes, it can be presumed as status epilepticus. Right? Considering this case as a case of status epilepticus, we should go for lorazepam, diazepam, whatever is available. Right? So we have to terminate the seizure attack. Right? So this can be taken as a case of status epilepticus. To go for diazepam or lorazepam. Now, a young traveler who visits rural spaces had taken something unhygienic and he developed abdomen pain with watery stools. So, what should be given? Is metronidazole. Metronidazole. Now, next question. Professor was teaching students about side effects of a drug which is gynecomastia in males or menstrual irregularity in females. Which drug she is talking about? This is, of course, here everyone is right. This is spironolactone, which is a potassium diuretic, acts by antagonizing effects of aldosterone. Early part of collecting duct. And if come to the side effect, just remember two important side effects. One is, of course, this question is gynecomastia in. Second is, since it is a potassium sparing diuretic, it can cause hyper. Next question. Which antidepressant which acts by inhibiting reuptake of both serotonin and noradrenaline? Yes, this is, we are talking about SNRI drug, is selective norepinephrine and noradrenaline reuptake inhibitor. This is venlafaxine. Serotonin, norepinephrine reuptake inhibitor. This is venlafaxine. Now, the next question. A person is showing resistance to isoniazid, rifampicin, kanamycin and ciprofloxacin. This will be labeled as extensive drug resistance. That is R. And how we define XDR? We have to, there is resistance to isoniazid plus rifampicin, then any fluoroquinolone. In the given question, it is oxygen, and any second line injectable. And in this question, clear? So this is XDR. I think most of you must be remembering there is only isoniazid plus rifampicin. We will call it here. That's simple, MDR. So this is XDR TB. Now next question. Patient has shooting pain on touching the face, on chewing or speaking or brushing the teeth. What drug will help patient? Yes, everyone is right, carbamazepine. But what is the condition? Clinical condition? Trigeminal. There is very sharp shooting pain in the trigeminal nerve, and we know that trigeminal nerve provides sensory supply to the entire face through it. three branches. Typical case of trigeminal neuralgia for which we can give carbamazepine. Next question, a patient was given primaquine, but he developed dark colored urine. What could be the reason behind this? Yes, this is glucose 6-phosphate dehydrogenase deficiency, and we know that there is one concept like hemolysis in C6PD deficient. That is this concept, and there are certain drugs like Capson, primaquine. The person is, yes, flavavin, just the list is very long. So we have to be very cautious while using these drugs in a person who is a known case of C6PD deficient. Yeah. Person is planning to travel to malaria endemic area. We should start chemoprophylaxis with which drug? Which drug should be given so as to make sure that he won't get malaria? Better answer is chloroquine. Chloroquine is the given drug for a person is visiting malaria endemic area. Which of the drug is not used for detoxification of a known alcoholic case? Which of the following is not used? Disulfiram is given, disulfiram is used. What is this flumazenil? What is flumazenil? Flumazenil is antidote for benzodiazepine overdose. Yeah. It has nothing to do with alcoholism. Flumazenil has to answer here. That's all we can give. Next question. A known case of epilepsy was started on lamotrigine, but and the drug was 50 milligram once a day, and this is increased every 2 weeks, and finally the desired dose of 200 milligram per day was achieved. Now this kind of step titration, why it is being done for lamotrigine? Why we couldn't give the desired dose starting from the day one? Any idea? Yes, it is very important to make sure that the whole desired drug of the lamotrigine is not started at once. It is gradually increased over a period of time till the desired dose. So this is very important. If you give the entire dose from the day one, that can lead to the development of skin rash. Very good. This is very important. The dose has to be gradually increased till the desired dose for lamotrigine. Then again, a patient who had traveled developed chills and rigors, and there is banana shaped gametocytes, peripheral blood smear, there is altered sensorium, and yes, this clinical picture is of very good. So this is falciparum area, and it should be managed by intravenous artificial. Right. So this is falciparum malaria, and of course you can see a little banana shaped gametocyte. A female patient has profuse dirty white discharge. Swift test is positive, and flu cells were also seen. Which drug will work? This is metronidazole, and I think most of you must be able to make the clinical diagnosis of bacterial vagina. This is a typical presentation of bacterial vaginosis where there is white discharge, positive Swift test, that is seminal odor, and clue cells where the vaginal epithelial cells covered by the bacterium and they lose their definite. So this is bacterial vaginosis. Known case of chronic asthma is on theophylline, and concomitant use of which antibiotic will demand reduction in the dose of theophylline. Yes, Pratusha is H more than 5 because there is decrease in the number of lactobacillus. Now, if a person is on theophylline, which of the following antibiotic? Perfect, everyone is right. This is erythromycin, because erythromycin will inhibit or will reduce metabolism of theophylline. So if you don't decrease the drug, it can result in toxicity. Okay? So you have to reduce the amount of theophylline if you are concurrently giving erythromycin. This is the reason why we need to add this. So it will inhibit the metabolism of theophylline, and that will increase the levels of theophylline in the body. So we have to reduce down the amount of. Patient with amoebiasis was given some drug, and then in a party he took alcohol. After that he developed all those flushing, nausea, vomiting. So which drug the patient was actually taking? Yes, the clinical presentation is disulfiram kind of reaction, and the person was on metronidazole. He is on metronidazole for amoebiasis. Next question, again very basic question and repeated so many number of times. A non-vegetarian has developed, I think we have already discussed first session. So first, metatarsophalangeal joint affection, similar episodes. This is a typical case of gout for which we need to, it's a typical case of chronic gout for which we need to give allopurinol, which will inhibit xanthine. Chronic gout. Next question, basic question, is on platinum based chemotherapy, maybe platin, and developed nausea and vomiting. So what drug can be given? Yes, this is palinosatron, that is member of ondansetron. Chemotherapy induced nausea, vomiting. A lady was on warfarin for prosthetic heart valve, and during the course of treatment she became pregnant. Now what needs to be done regarding warfarin therapy? Yes, warfarin, it's better we replace it with piperine in a pregnant lady. So better replace warfarin with piperine, comparatively safe. Ladies has a history of previous delivery, Down syndrome. Now she has been started on lithium therapy for bipolar disorder. And what problem can occur? Yes, this is Epstein anomaly. If a pregnant lady is taking lithium, so there is possibility of Epstein anomaly. Please remember, especially for right. A person is planning to go to Ladakh. What drug he should take to prevent the possibility of is actually high altitude cerebral edema? What? Yes, it's important, acetazolamide. So and it has to be started before reaching high altitude. Once you reach there, then you start, it won't make any difference. It has to be started before reaching high altitude. It has to be started. Yes, motion sickness is different from mountain sickness, and especially we are more concerned with this particular serious complication, that is high altitude cerebral edema, right? So acetazolamide. Enough for this session. We will meet after Good evening, everyone. Now, in this session, we will take use of medicine. So, starting with the very first MCQ from Pathology, where a person presented with weakness and tingling of the extremities. There is weakness of the flexors and extensors of the lower extremities, but more importantly, there is diminution of sensations of vibration and position in all the four, right? So if you just go through with the entire presentation, what you can make out is that since there is affection of vibration and position sense, so this is a disorder of which area? This is some condition which is affecting the dorsal column. And yes, this entity is known as, this is subacute, very good. This is subacute combined degeneration, that is SACD, and should be associated with deficiency of vitamin B12. So the moment you have any question about deficiency of vitamin, which particularly discuss with the affection of dorsal column in terms of proprioception, vibration, affection, have to think of SACD, subacute combined degeneration. Yeah. Now, forward to next question. A 12 years girl from Nigeria, African country, then she is having constitutional like night sweat, fever, loss of weight since last few months. There is an intra-abdominal mass and associated with enlargement of the lymph nodes. But what is seen on the biopsy of lymph node is that there are sheets of lymphocytes which are having interspersed macrophages. So there are a lot of lymphocytes. Now here, I think, yes, so the two classical points which are enough to make a clinical diagnosis of Burkitt's lymphoma. Yes, so this is a case of Burkitt's lymphoma, and yes, the typical translocation is 8 to 14. This is a case of, yes, and this is actually the starry eye, typical pathological feature of Burkitt's lymphoma. And yes, it is caused by Epstein-Barr virus and principally like related to African area. So very easy to identify. The moment you have a word, a patient of African origin, especially a child, always think of the kids. Okay. Moving to next question. Boy presented with lethargy, and initially he was good in studies, but few times getting down, and there is history of repeated blood fusions. And when you did peripheral blood smear examination, you saw crescent shaped RBC. Now I think the diagnosis is very clear. The moment you see these kind of RBCs, the diagnosis comes out to be, will be the clinical diagnosis. Is sickle cell anemia. And what you need to do, there will be a hemolytic presentation, so we need to give blood transfusion. Okay, so blood transfusion. This is a typical case of sickle cell anemia. Now coming to next question, there is a patient who is a known case of hypertension, and he had developed palpitation, dyspnea, and encephalopathy. Right? Blood pressure was extremely high, 220/140 millimeter of mercury. Now, which of the following drug is of no use in such a patient? Now we can see that the patient is going into a state of hypertensive encephalopathy, and our priority is to reduce down the blood pressure. Now, if you look at the option in B, C, D, all hypertension properties, and the drug A, that is mannitol, it has nothing to do with reduction of. Yes, it can be used for reducing intracranial pressure. Mannitol, it is valuable in reducing intracranial pressure, but nothing to do with reduction of blood pressure. Yeah. So the answer has to be mannitol. Yes, yes. Right, Puneet. So it has nothing to do with blood pressure. Now, next question. A patient was found to have raised JVP, steep Y descent. What can be the diagnosis? Steep Y descent. Very good. The answer is constrictive pericarditis. And in cardiac tamponade, we will find absent Y. Okay? Just make sure that you don't mix in the two. In constrictive, it is steep Y descent. In cardiac tamponade, there is absent. Already we have discussed much about the JVP waves, so we it again. Patient has a blood pressure of 80 by 40 millimeter of mercury with soft heart sounds and absent by descent on JVP. I think everyone can very clearly make out the answer as cardiac tamponade. So blood pressure value of 80 by 40, this is then soft heart sounds, some use the full heart sound, distant heart sound, just because of collection around the heart. Then next question, there is a case of Marfan syndrome, and he had presented with severe generalized hearing pain, which is located to the chest anteriorly and going back to the interscapular on the backside, associated with sweating and weakness. And when you measured the blood pressure, it came to be very high, that is on 140 millimeter of mercury. XHS shows widening of superior mediastinum, and ECG shows tachycardia. What can be your diagnosis? Now, when you see a typical case of, when you see a case of Marfan syndrome with a typical history of anterior chest pain and going backward towards the interscapular area, and it's like a kind of tearing pain that is very indicative of aortic dissection, right? This is a classical case of aortic. It's a classical presentation, aortic dissection, although somewhat similar to be seen in acute pancreatitis sometimes, but for severe pathology, this is very classical for aortic dissection, right? Now here, if you see the blood pressure is extremely high, what happens? You take the layers of the heart, intima, then we have the media, and finally we have the adventitia. Intima, the media, and finally adventitia. So whenever there is so much high blood pressure, there is possibility that the blood might create a tear and will move inside the wall of aorta, and then it will keep on separating the layers of wall of aorta, and therefore we use the word aortic dissection. Dissection means just separating up. So the velocity of the blood is so high, it just tears apart. So that is aortic dissection, and that can be seen as widening of the superior mediastinum on X-ray, and there is sinus tachycardia. Now, when we use the word sinus, it means when we use the word sinus tachycardia, actually sinus word shows that every wave pattern, everything is normal. It is just that the heart rate has increased heart rate, and that can be, if you check ECG, you can see that the duration of QRS is reduced, right? Otherwise, the waveform pattern, all waves are normal. It is just that the heart rate is more and is reflected as shortening of the duration of QRS complex. So this is sinus tachycardia. So this is a classical presentation for aortic dissection. Yeah, aortic dissection. In typical complaints, anterior chest pain, tearing through, going up to the back into the interscapular. Yeah, so aortic dissection. Now, a lady presented with joint pains and rash over face. She don't have any fever, and but ESR is high, and we have small warty vegetations on both sides of the heart valve. So again, I think this is very easy to answer. This is a typical case of, SLE. This is SLE, and what we see in SLE is Libman sac endocarditis. Everyone can answer. Very good. Now, fixed and wide split, second heart sound. This is heard in very good, very good. The moment you find the word fixed, your answer has to be AST. Perfect. Now, just a little bit of physiology of second heart sound. Whenever we discuss second heart sound, we always write it like A2. So there are two components. Yes, Puneet, absolutely. There is only one condition where we find this word fixed. Now there are two components, aortic and pulmonary, and there is a gap between the two components which increases further in cases of inspiration, and this reduces during expiration. So here, this gap between the two components increases during inspiration and it reduces during expiration. This is the normal physiology. Now, if I'm using the word, you say wide split. If I'm using the wide split, it means the normal gap which was seen in both phases of respiration, it will increase further. Right? So suppose if in normal, if this was A2 and this was P2, now what will happen in wide split? A2, P2, right? So the gap between the two components of the second heart sound will be more. So this is wide split. Now, what can be the cause of wide split? By simply using the word wide split, it means either there is early closure of aortic or there can be delayed closure of P2. So it means, suppose if we are using A2 and P2, either there is possibility that P2 remain at position, A2 shifts a little early, so there is early closure of A2, that will again widen the second heart sound, or there is possibility that A2 remains at its place, closes on time, but there is delayed closure of P2, that will again widen the second heart sound. So in terms of widening, you can mention two causes, either early closure of aortic component or either there is delayed closure of the pulmonary component of the second heart sound, right? So these are the two possibilities where you will get wide. Now when we use the word wide, it means that gap between the aortic and the pulmonary component is more. It is just, it remains same during expiration and inspiration. So that variation is not seen with the phases of respiration. Whatever the distance, like if suppose A2, P2 is like this, there is a widening, there is a gap, but it is not changing with the phases of respiration. What happens in another cases, whatever the gap is there during expiration, it will widen a little bit more even during inspiration. So that gap changes as per the phases of respiration. But whenever we are using the word fixed, that gap is, you can say it is fixed. Or whenever you find the word fixed, wide split, think of ASD. Now, taking the same concept, we can discuss one more entity, and that is reverse splitting. Right? Anyone, what is reverse splitting? Just you can just reverse the pattern of wide splitting. So again, if I'm saying that wide splitting is because of early closure of A2 and or delayed closure of P2, in reverse splitting you can do opposite. So early closure of P2 or delayed closure of A2. Right? So what will happen? The sequence will come out to be P2 A2. So this is reverse splitting. Right? So the sequence has reversed. Instead of the normal A2 P2, now it has become P2 A2. Clear? So yes, Puneet, you are absolutely right. The sequence is now P2 A2, and to remember it for long, like in short, I can tell you what can be the cause for delayed closure. Delayed closure, you can remember, like if there is the impulses, if they are reaching late, and the usual cause is bundle branch, so that will cause delayed closure. If you want to discuss the delayed closure of pulmonary component of the second, you can think of right bundle branch block. If you are discussing delayed closure of the aortic component of the sound, you can think left bundle. So this way, at least you can correlate one of the cause. So the list is very. So this is wide split, wide fixed split, and reverse splitting of second heart. Please remember this. Now, next question. Yes, Puneet, you are absolutely right. Pulsus paradoxus. Where we can find pulsus paradoxus? Anyone? Pulsus paradoxus. So, like during, to understand this, you have to understand a little bit of normal physiology. During inspiration, yes, those who are marking B, they are right. Those who are saying B, they are right. Now let us take the concept first. Now during inspiration, what happens to systolic blood pressure? What happens to systolic blood pressure? Anyone? What happens to systolic blood pressure during inspiration? Will it increase? Will it remain unchanged, or will it decrease? Very good, Raghu. It will decrease, right? So there is a fall in blood pressure, right? Number one. Now there is a, yes, Puneet, right? So there is a fall in systolic blood pressure, but the magnitude is always less than 10 millimeter of. Raghu, absolutely fine. So if suppose during expiration the systolic blood pressure is, you say, 120, during inspiration it can fall up to 110, but it won't go below 1. Yeah? So that is the concept. Now what happens in pulsus paradoxus? This systolic blood pressure fall, this is normal value. Now what happens in pulsus paradoxus? this fall in systolic blood pressure on inspiration, it exceeds the normal value of 10 millimeter of. So in simpler words, what you will say, that there is exaggeration of normal physiology. So the normal physiology, what we have discussed, it has become a little bit more exaggerated, and that is pulsus paradoxus. Right. Now, what is the paradox over here? The paradox is that whenever you auscultate a heart, and if you can hear heart sounds, you must be able to feel the pulse. But the pulsus paradoxus is entity where you will be able to auscultate the heart, but you won't be able to pulse. So that is the paradox, because the normal teaching is whenever there is a heartbeat, there has to be a pulse. But in this case, you can auscultate the heartbeat, but you won't be able to feel the pulse. So that's why we use the word paradox here. Now, for pulsus paradoxus, you can remember two set of conditions. One relates to the heart and another relates to the respiratory system. So in respiratory system, please remember COPD, whereas for heart, you can remember two conditions which starts with C. So like in respiratory system, any condition is included in COPD can be the answer here. Whereas for CVS, just remember two conditions. One is constrictive pericarditis and second is cardiac. Right? So remember this much. Just remember constrictive pericarditis and cardiac tamponade, and here you can remember at least COPD. Right? So this is pulsus paradoxus, and this is just an exaggeration of the normal physiology, which says that, yes, you're right, which says that there is fall in systolic pressure on inspiration. Now, on arterial blood gas analysis, pH was 7.28, bicarbonate 23, and PaCO2 is 80. I think this is one of the easiest question which you can answer easily. pH, normal value for pH is around 7.35 to 7. Here, any value less than 7.35 is acidosis. One thing is clear, that this is a case of acidosis. Now, for acidosis, you can have two reasons. Either it can be respiratory or it can be metabolic. Now, respiratory acidosis will result when the PaCO2 is more, and metabolic will result when there is low bicarbonate. Here, so in question we have PaCO2 of 80, which is higher than the normal range 35 to bicarbonate is clear. So this comes out to be a case of respiratory. This is how you can, this kind of question easy, provided you just apply the concept peacefully. Next question. Elderly patient has complaint of imbalance bile stand, and there was loss of proprioception and vibration. What should be given to this? I think we discussed that this is a case of spine degeneration because there is affection dorsal column. What we need to give? Answer it quickly. So B12. Yes, Raghu, absolutely. Now next question, it's just a repetition. So wide QRS complex and tall T waves, everyone can answer this typical case of anemia. Here you can see the tall T waves. Yeah. So this is hyperelemia. Right. Now this is again one very favorite topic, like most of the time. So there is weakness of limbs, and this is worse in the evening. Yes, Bhavana. So weakness of the limbs, which is worse in the evening time, and this improves with adrophonium tests. It goes more in favor of myasthenia gravis. Yes, sometimes you might process as well MCQ statement. Very good. Hypersensitivity. Classical, you can say, with exertion. Weakness which comes with exertion. Therefore, it is more pronounced during the evening hours. Next question. A laborer who was working in 42 degrees found in an unconscious state, which will not be seen in a patient. Yes, this case of, what is the clinical diagnosis here? What is clinical diagnosis? Heat. There is no concept of sweating here. So heat stroke, working in such a high temperature. Now, the child has highly flexible fingers, and he can even touch the back of his hand by bending the fingers at the wrist. What can be this? Yes, perfect. Ehlers-Danlos syndrome. Hyperflexible fingers. Ehlers-Danlos. Yes, right. Now, a young tall male is trying to have baby since 2 years, but the wife cannot conceive. He is having azoospermia, then pubic hairs with gynecomastia. I think the diagnosis is quite obvious. This is a case of Klinefelter. Very good. Now, if a subject is volunteering for blood donation, I think everyone can answer this. Is not needed. Yes, need to go. If a central line has been put in the internal jugular vein, which investigation will help us to confirm that the, yes, so it is, will confirm that the line is well in place. So this chest X-ray. Here you can see. Okay, so this is proper placement chest X-ray. Now, a lady presented with complaints of palpitations, headache, and sweating. Her mother had died because of adrenal cancer. There is tachycardia, there is hypertension, respiratory rate is okay. So, what investigation should be done? And before that, you should make provisional diagnosis first. What you this can go for 24 hours fractionated metanephrine, few chromosomes. Now, person was on warfarin treatment. Now he's also started on ATT. Yes, catecholamines can be done, but this is little better. The metabolic byproducts. A is little better than D. Yes, be done, but A is better than D. A person is on warfarin and he was started on ATT. What will happen to the effects of warfarin? Raghu, you have spotted the right drug, but answer is not. See, rifampicin is microsomal enzyme inducer. Microsome enzyme inducer. So what will happen? If it is given with any other drug, it will promote metabolism. It will promote metabolism of any other simultaneously given drug. Here, what will happen? Because if it is being given with warfarin, so it will metabolize warfarin, and therefore the pharmacological effect of warfarin will increase effect of MCQ, and therefore your answer will come out to be decrease in the pharmacological effect of warfarin. And based on the same concept, there was one more question in which it was said that lady was on OCP, then she was started with ATT, and she became pregnant. What is the reason? The reason is same, that rifampicin acrosomal enzyme inducer led to the metabolism of OCPs and reduced their efficacy. Lady became, okay? Yes, OCP failure, contraception failure. So the concept is same. It is a microsomal enzyme inducer. Whenever we are giving rifampicin or AD to any person, we should firstly ascertain whether he is on some other medication or not. If he is or she is, should be addressed properly. If 3.2 potassium is 3.2, then definitely you have to. Now here the potassium values are 3.5 to 5.5. Normal range is the case of hypokalemia. What we need to do? We need to supplement. We will give potassium. So in hypokalemia, we have to give potassium chloride. Insulin has to be given in hyperkalemia. Please remember, this is given in hyperkalemia because it promotes the intracellular movement of potassium. Wherever the potassium is lying outside, it will push them back in. No problem. Happens. Let's make sure that you don't repeat the mistake. Hypokalemia, give potassium. Moving forward to next question, you have snake bite. After that, the patient has myalgia, pain in muscles, myelitis, breakdown of the protein, and there is progressive flaccid paralysis. Which snake? Now, if you look here, this is affecting the muscles as such. So, yes, which of the venom of which snake is myotoxic? Venom is myotoxic here. I think now everyone can answer it. Is the snake myotoxic? Perfect. A child has a 2-week history of not feeding well and excessive irritability, and there is a history of TB in the family. And when lumbar puncture was done, what you can expect in this case? So there is already a family member who is having TB, so we can assume that this child might also have developed tuberculosis. So in lumbar puncture, we can have a picture which is in tuberculosis meningitis, and that will be like lymphocytosis, low sugar and high, okay? Low sugar, high protein, and lymphocytosis. Very good. In we have already discussed it many times. Muffled heart sounds, hypotension, raised JVP. What you will see in JVP will be B. Yes, perfect. Absent by descent and a prominent X. This is even will agree this is a case of cardiac and extra. Here. Next question. Elderly male is presented with a complaint of not making any sense while speaking and nonsensical grammar, though he can speak quickly. He was communicating normally before this. So what is this? In speech is fluent. Speech is fluent, but it is of not related to the question asked. So it is case of fluent aphasia. And yes, this is Wernicke's aphasia. Wernicke's aphasia. Here is Wernicke's. And I think which part of the brain? Superior so this is Wernicke's aphasia or fluent aphasia, sensory aphasia. Next question. Scissoring gait may be seen if there is increased firing of which nerve? Before this, you must what actually is scissoring gait. Suppose if this normal person, now what happens in scissoring gait? Limbs are something like this. So they cross over. Right? And in terms of anatomy, you will say that there is adduction because this is going here and this is going here. So this is adduction, and which nerve cerebellar we can have, but in terms of nerves of the lower limb, there is adduction of both sides, and this adduction or the adductors are supplied by which nerve? Right? Is in terms of nerves you can discuss it. Adductors are overactive, and since they are supplied by obturator nerve, so we can mark the answer as Wolff-Parkinson-White syndrome. What you will see in Lurching gait, yes, this is Trendelenburg gait of superior gluteal nerve, which affects the abductor muscles. So Wolff-Parkinson-White, broad URS complex. Now, what is the pathology in Wolff-Parkinson? Pathology. Now, what happens? The usual route is that say node of conduction, AV node, bundle of, and then we have the Purkinje fiber, something like this, right? And these Purkinje fibers will take the impulses to ventricles. So this is the usual route. But what happens? There is a bypass channel. Yes, this is a necessary pathway. What happens when the impulses they reach the ventricles? Right. So the impulses they reach to the ventricles through this bypass channel, and that what increases the duration of the URS complex. Yes, for treatment you can give procainamide, amiodarone, or flecainide, or sometimes you can do ablation of this tract. This is the usual route of transmission of impulses, but here you can see this is aberrant pathway or shortcut. pathway is connecting the atrias with ventricle. So you will see a long QRS complex. We'll discuss pathway of Kent. And also you can see a delta wave. What is this delta? It is slurring of stroke of, normally it should be this. Here we have slurring that is known as delta. Yeah. So this is Wolff-Parkinson syndrome, and treatment wise, give I'd sometimes you can try this accessory pathway, which is the root problem. This is Wolff-Parkinson. Long QRS complex is very important. What are in? Please remember. Next question. Lady has difficulty in eating because of dry mouth, and she have grittiness in the eyes due to dry eyes. There is dental caries. Very easy to answer. So this is Sjogren's syndrome, and whenever you find the word dry, like dry eyes, dry mouth, this dry mouth will promote dental. This is the usual presentation. Please remember. Now, next question. Elderly male, low backache, LR, AFT is deranged, LFT is normal with normal albumin, but gamma globulins are disproportionately raised, and multiple lytic lesions on X-ray. Classical presentation for multiple myeloma. Classical presentation. This is a tumor of plasma cell dyscrasia. Okay. A patient presented with pedal edema over the foot, CVP is raised, and there is ascites. What is the answer? It is actually right-sided heart. Right-sided heart failure. Clear. Raised CVP and going up to the mandible with means. Next question. 10 years old. Yes, correct. Chronic venous congestion of liver. Yes. There is a 10 years old patient who is having flank pain, and there is smoky colored urine. There is RBCs in urine which are dysmorphic. This is again a classical case of post streptococcal glomerulonephritis, PSGN. Then next question. Young lady with petechiae, palpable spleen going till umbilicus, WBC is so high, and there are immature white blood cells in the peripheral blood. What you can think of? Anyone? Yes, the moment you find massive splenomegaly, is massive. 99.9% this is CML in terms of leukemia. So it can be seen in malaria or Kala-Azar. Right? So this massive splenomegaly. Petechiae can be a manifestation of platelet count. Next question. A female patient has unilateral pulsatile headache with sensitivity to light, photophobia, and it might increase after eating meals. What can be the diagnosis? Yes, this is classical for migraine. Migraine. There is unilateral headache, usually bilateral, with photophobia or other precipitating factors, especially emotions, anti headache. Now, cluster headache principally around the eyes, so periorbital, and tension headache, it is like a band around. Of course, tension means there is some sort of problems going on. So, there are the three. A patient has difficulty in doing heel shin test. Heel shin test. Rapid movements in his hands. Whenever we tell the patient to do repeated movements, he is not able to do the heel shin test. This is actually rapid alternating movements. And one more method is like you can tell the patient to do pronation and you want to check, yes, dysdiadochokinesia. Very good, Puneet. This is dysdiadochokinesia. The patient is not able to do rapidly alternating movements, right? So this goes in favor of, yes, this is cerebellar lesion. Right? Very important. Another method is finger to nose test. All again rapid alternate. Next question. A smoker with copious yellow sputum is more in the morning and increases with postural change. What is this condition? Postural drainage. Anyone? Absolutely fine. This is bronchiectasis. Bronchiectasis and yellow colored sputum. The moment the patient changes the posture, it just comes out. Bronchiectasis. And mostly it affects the left lower. Now, a patient has diagnosed to have a tumor in the ileum and there is increased urinary high hydroxyindole acetic acid. Now, what condition can you think? Increased urinary yes, this is carcinoid tumor. High hydroxyindole acetic. A smoker, yes, absolutely right. This is carcinoid tumor. A smoker had developed blood tinge sputum. Yes, right, carcinoid. During cough, and when we did chest X-ray, absolutely normal. Now, what should be done next? A smoker with, you can say, hemoptysis and X-ray chest normal, what you can do next? Anyone? Yes. Like, see, a smoker with hemoptysis, we can think of the possibility of carcinoma, bronchus or lung, right? So, if X-ray is normal, we should go for CT test, and if this shows us some mass or something else, then we can do a bronchoscopic guided biopsy. So, for this particular question, considering the possibility of carcinoma, since the patient is a smoker, so we can go for CT chest. CT chest seems a better answer, and we are not going into like considering it as a case of tuberculosis, so I think sputum does not hold that much. But sputum won't give us much information in this particular case, because we are taking it as a case of carcinoma, bronchus, carcinoma lung. So better take a CT chest, and based on that we can proceed further. So that will give a more valuable clue, because the word smoker has been given, so we have to think of the possibility of carcinoma. We can't, we need, no need to go for tuberculosis, because even if it is tuberculosis, definitely it would have shown something on chest X-ray. Chest X-ray is normal, so we can exclude tuberculosis. Possibility more goes in favor of tumor somewhere, better evaluated on CT. Next question. Patient presents with throbbing unilateral headache with nodular thickening along the temporal artery. Biopsy shows giant cell. The answer has been given. There is granulomatous vasculitis. So this answer is temporal. That's right. There is thickening of the temporal artery, especially superficial temporal artery, and it looks like a thick cord, and this may be associated with visual jaw, and biopsy is must. Biopsy is must, because at times we have to start the patient on long-term steroid, need to take the patient on long-term therapy. We have to confirm this is a typical case of temporal arthritis affecting the super pulse. Next question. Female has fever, arthralgia and erythema nodosum, but in the chest X-ray shows bilateral hilar lymphadenopathy. Mantoux comes out to be negative. What will be your diagnosis? Yes, perfect. This is sarcoidosis, right? So for sarcoidosis, this is one very important clue: bilateral hilar lymphadenopathy. And Mantoux, like, we look for in duration, it is more than 10 millimeter. The interpretation is that the person has been exposed to tubercular protein. So even if Mantoux is positive, it does not say that the patient is suffering from tuberculosis. It just tells us that the patient has been exposed to tubercular protein. It can be by the way of BCG vaccination, can be because of TB infection. It does not guide us, but yes, we can go for, this is always a component or a part of our workup. We always go for it. If it is negative, we can go to sarcoidosis. Bilateral hilar lymphadenopathy is quite important here. Now, next question. A child with a one-day history of high-grade fever, and there is loss of consciousness, LR, but there is no focal neurological deficit. Hypoglycemia is also seen. Classical case of, very good, this is cerebral malaria, which is because of plasmodium. Okay. Yes, cerebral malaria. You're right. Now, next question. Secretory diarrhea, hypokalemia can be seen with which tumor? VIPoma. Very good. So for VIPoma, you can remember a mnemonic, that is WDHA. So WD stands for watery diarrhea, H for hypokalemia, and A for achlorhydrin. Very good, Pratik. So this is lipoma. Remember? Now, next question. Elderly male has persistent and worsening cough. There is hemoptysis, chest pain that worsens with deep breath or any exertion. There is dyspnea, and there are frequent attacks of bronchitis. But more importantly, the term is weight loss. Now, what you will think of? Elderly, hemoptysis, weight loss. Anyone? Yes. So the moment you have this kind of terms, always think of the possibility of bronchogenic carcinoma. Weight loss, told you in the weight loss to be kept in association tumor anywhere in the body. Now, a female has difficulty in standing up from squatting position, cannot comb her hair, and has violaceous allelotropy rash around the upper eyelid. What is this? Yes, yes, perfect. This is dermatomyositis. So this allelotropy rash is the classical picture. Violaceous means the purple color. So dermatomyositis is what allelotropy rash looks like. Allelotropy, slightly purple in color. Next question. A child has recurrent lung infections. Yes, yes. Thick sputums and bronchial wall thickening is there. He is having steatoria since birth. What condition should be? Absolutely right. This is cystic fibrosis. And what happens in cystic fibrosis? The secretions are thick. That what lead to steatoria. Steatoria means, what is steatoria? Fat in. So there is malabsorption of fat. So because the pancreatic secretions are also thick, so patient has steatoria. Then recurrent lung infections because the bronchial secretions are also thick. So sometimes in a newborn we can also have that meconium ileus kind of picture. Very good. This is classical presentation for cystic fibrosis where the secretions are thick. Now next question. A patient was treated for pulmonary tuberculosis and he was given rifampicin, isoniazid, pyrazinamide and ethambutol. Now he is complaining of pain in joints. What you will order? Yes, very good. We will go for serum uric acid because there are few offending drugs which can cause hyperuricemia, right? And we know that hyperuricemia can present as enough mind. So this is actually, so we should check for, yes, gout. Very good. So hyperuricemia can be side effect of pyrazinamide as well as ethambutol. Very good. Please consider this. Next question. Elderly male has right hip pain and back pain, and when we did workup, hemoglobin was less, calcium was high, creatinine was also high, and bone marrow biopsy showed percent plasma. I think this is a classical picture of multiple myeloma. Low back pain is there, then anemia. This is hypercalcemia because normally the levels are 9 to 11. Then creatinine normally should be around 1. Normally around 1 high, so it shows that there is some renal insufficiency. Above all, plasma cells increase, so multiple myeloma. Very good. Next question. A patient has acute dysentery and followed by this Yes, Gulshan. Followed by this, he has bilateral ascending quadriplegia. But pain and proprioception was intact. First differential diagnosis has to be, yes, you're right, this demyelinating polyneuropathy, that is Guillain-Barré syndrome. And yes, this acute dysentery could be because of Campylobacter jejuni. And when we are using the word ascending paralysis, what does this mean? Ascending means ascending means firstly he will have weakness of toes, then ankle, leg, knee, and finally it will go towards hip. So this is ascending paralysis. So this is ascending paralysis, and one of the earliest presentation is like a patient will come to you and he will say that footwear slips, feet, not able to keep the footwears in position. So that is initial complaint showing distal myopathy. There is involvement of the distal muscles. And what is good, what you will see in CSF examination, CSF examination, CSF examination, albuminobiological, here. And treatment wise, you would like to do IV immunoglobulin or plasmapheresis. Very good. And the good thing about this condition is that it is a self limiting condition, and majority of the patients recover fully. Good prognosis. This is predominantly a motor condition affecting mainly the. So this is Guillain-Barré syndrome. There is a past history diarrhea which is caused by Campylobacter. Next question. There is history of the patient has developed UTI infection, and then he developed periorbital edema and plenty of RBCs in urine. Blood pressure is high and CG3 levels are used. There is anti-DNase antibody. What very clear, this is post-streptococcal glomerulonephritis. Now this additional word has been written just to confuse you, but if you look at other features, these are extreme, all are going in favor of PSG. Past history of, there is an indicator of streptococcal infection. So this is PSG. Now next question. There is breathlessness, and on percussion you find dullness, and breath sounds are also heard less, especially in the infra-axillary location. What can be the diagnosis here? If you percuss and if you find dullness, you can remember like stony dullness or something like liver dullness. This suggests that there is collection of fluid. There is collection of fluid, and that collection of fluid is known as pleural effusion. Now, if there is any collection of air, you say pneumothorax, air will give you hyper resonant note on percussion. Here, it will be just like you are tapping on a pot, just like tapping on a pot, which is not filled with water. So the answer is B. No problem. Dullness fusion, resonant, pneumothorax. Just make sure, don't mix up. A patient has palpitations, then pulse is irregular. There are no P waves on ECG. I think it is quite easy to make a diagnosis of atrial fibrillation. Very good, because we know that P waves are because of real fraction, and in a case of atrial fibrillation, the atrium are simply vibrating, so there is no proper P wave, and we call it absence of P. So the moment you find absence of P wave, think of atrial fibrillation. Pulse is irregular. A patient developed symptoms of dementia, and he was diagnosed as a case of Alzheimer's disease. Now, which neurotransmitter is reduced in this condition? Very good. The answer is A, acetylcholine. And see, this is Alzheimer's is a classical case of cortical dementia. And here what happens? There is shrinkage of the cortex of the brain, is widening of the ventricles. So in one sense you can say that the functioning brain tissue reduces. So the acetyl level also reduces, and therefore what we do while treatment of Alzheimer's, we give those drugs which inhibit the enzyme which degrades the acetylcholine. So we give acetylcholinesterase inhibitors, answers, rivastigmine, galantamine, or donepezil. Okay, so whatever the acetylcholine is there available, we just want to make sure that it is there, it is not degraded more. This is Alzheimer's. Now, next question. Patient has moderate dehydration and urine osmolality is low. What can be the? Yes, no problem, Rinkesh. Don't mix up in the exam, please. So there is moderate dehydration and urine osmolality is low. Yes, dehydration means there is loss of, you can say, fluid from the body, and that manifests as the low osmolality. It means the increased volume, and increased volume of urine. I think everyone will agree that it is diabetes. Yeah. So this is diabetes insipidus. Hypotonic urine and dehydration because of the fluid is going out in the form of, yes, Siad will have high urine osmolality. It means concentrated urine. Next question. SPSAG, surface antigen is negative, envelope antigen is negative, IgG anti-core antibody is positive, and anti-HBS is positive. Now what is this? Here, see, there is no surface antigen, right? It means there is no present HBV infection. This is one thing. Now the patient does not have current infection, so neither there is carrier state, nor there is chronic hepatitis states, nor there is acute hepatitis B infection. So these three things you can rule out just taking this particular fact in notice, right? But what you can see here, that there is IgG anti HPC positive. It means there is past infection. This is an indicator of past infection, and this is an indicator of immunity to HBV infection. So immunity can be gained in two ways. either infection has solved, this is one way, or secondly, if someone has been vaccinated. Right? So here there is past infection, so we will presume that the person has recovered from previous hepatitis B. Clear? So if there is anti-HBs positivity, there are only two possibilities: either the person is vaccinated or he was having a previous infection from which he has recovered. And if his surface antigen is negative, it means there is no present infection. So there is no possibility of chronic, there is no possibility of acute, or there is no possibility of carrier, because in all these three states, HBsG has to be positive. All the three conditions, this has to be right. So this is how you can answer this particular. And in case of immunity because of vaccination, this will also come out to be negative. Suppose if this is negative, then your answer will be just look like this. So next question. Young female has dyspnea on exertion and there are macrocytic RBCs and serum methylcobalamin level was normal. What should be given to this patient? Yes, because whenever we are saying macrocytic anemia, there are two possibilities with us. You can just recall the concept of megaloblastic anemia. So there are two possibilities. Either it can be because of deficiency of vitamin 12, it can be deficiency of folic. Now just to rule out or the differentiate between these two conditions, we will go for serum methylcobalamin levels. So if this is normal, means vitamin B entity is ruled out. So what are you left with is folic acid as the deficiency factor for macrocytic anemia. Now next question. Elderly male with breathlessness and occasional chest pain. He has got a high volume pulse. BP is also high. And then there is displacement of apex veet lateral to the mid clavicular line. What is the usual site of the apex veet? Clavicular line. And there is an diastolic murmur. Can you make the diagnosis? I do agree that diastolic murmur is heard in mitral stenosis, but it is not the only condition in which we will find diastolic murmur. Now here, what you need to address, there are certain more points which you need to address. High volume pulse. Number one, high volume pulse. Number two, there is hypertension, right? And so there is hypertension. And this high volume pulse is known as bounding pulse. Clear? So what will happen? There is high volume pulse, the flow of the blood will come and it will strike the examining finger and it will disappear quickly. Right? So this is high volume pulse, and whenever we are discussing diastolic murmur, you have to, yes, you can make out two conditions. Diastolic murmurs, it can be because of any mitral valve pathology, it can be because of aortic valve pathology as well. Right? What will happen if there is stenosis of mitral valve? We have a diastolic murmur. If there is regurgitation of aortic valve, we will have a right. So diastolic murmur can have two possibilities: either the stenosis of the valve above ventricle or regurgitation of the valve after ventricle. Right. So I think if you take the two differential diagnoses for this particular case, I think you can make out the better answer. What it will be? What it will be? MS or AR? What will be your answer? Out of these two conditions, what will be your better answer? Anyone? No, aortic insufficiency will be a better answer here because of this high volume bounding pulse. If you are having a case of mitral stenosis, apart from this mid diastolic murmur, in a case of in a mitral stenosis, you will have a mid diastolic murmur, and this will be accompanied by an opening snap. So there will be an opening snap as well. Clear? And of course, whenever you will have a case of mitral stenosis, there will be no bounding pulse, and there will be a past history of rheumatic heart disease or rheumatic fever. Clear? So the clinical presentation of mitral stenosis revolves around the past history of rheumatic fever, because we know that is the most common mitral valve is the most common valve which is affected in rheumatic fever. Clear? So please don't ignore high volume pulse, please don't ignore high blood pressure, and then you will never be wrong. So this is how we can differentiate the two conditions. And of course, AS, MR not in consideration in this particular case. Let's move forward. There are distended neck veins which increases further on inspiration, and regular pulse was there, which is visible better than being felt on deep inspiration. There was no murmur, but yes, there was third heart sound. Now what you can think here? Very good, very good. The classical presentation, what is given here is small sign. This is a small sign. And what is small sign? Normally what happens when we inhale, the JVP should come down, but what happens in small sign? There is further increase in JVP on inspiration. So it is against the normal physiology of inspiration, and whenever there is a small sign, you have to think of only one condition, that is, yes, Puneet, you are absolutely right, this is constrictive pericarditis. So this is small sign, constrictive pericarditis. Please remember constrictive pericarditis. Next question. A patient has severe, sudden onset of severe headache, and he says that he never felt this kind of headache before. He is hypertensive. What you will, all of you are absolutely right. This is subarachnoid hemorrhage, and this classical presentation is actually thunderclap. So there is hypertension also, and this subarachnoid hemorrhage, this is usually because of rupture of aneurysm in the circle of Willis. Okay? This is subarachnoid. Headache is frontal sinusitis. That is frontal sinusitis. Anyway, so this is a classical presentation for subarachnoid hemorrhage. And when you will do lumbar puncture, you will find that it is stained with blood, because the blood has moved into the right place. Next question. Child has fever of 11 days duration, and lumbar puncture showed 75% mononuclear cells, sugar is less, protein is high, and there is upper lobe involvement of chest X-ray with enlargement of hilar lymph nodes. What can be the diagnosis here? Yes, this is a classical case for tubercular meningitis. Right? So you have everything related to TBM. Apart from that, you are also getting a radiological evidence of pulmonary tuberculosis, meningitis, and pulmonary tuberculosis. Next question. There is a patient with breathlessness and occasional dry cough, and when you auscultate it, you find bilateral basal clefts. There is a decrease in TLC and vital capacity, but the ratio FV1 to FVC is normal. I think very easy to see. What is this? This is restrictive lung disease. This is restrictive lung disease, and perfect example is pulmonary fibrosis. Restrictive lung disease. Very good, Prithvi. Next question. A patient presented with tremors, rigidity, bradykinesia, and when we did MRI, we saw that there is loss of normal hyperintensity on the both side of nigra. Which neurotransmitter is affected? Yes, this is a classical case of Parkinsonism with involvement of substantia nigra. This is dopamine. Next question. Clinical finding in a case of lower motor neuron disease of the right 12th nerve. Anyone? Element type of paralysis of 12th cranial nerve. Very good, very good. So whenever you will tell the patient to protrude the tongue, it will deviate towards the same side. Okay? It is deviation of tongue towards same side. This is for lower motor neuron. Please remember. Deviation same side, and this is actually flaccid, is the presentation for lower motor neuron paralysis. So this is flaccid deviation towards same side. This is very important. So the moment you tell the patient to protrude the tongue, it will roll over to the right side. Next question. A patient was evaluated for paraparesis, and there was severe muscular atrophy, absent DTR, and absent Babinski sign. What does this indicate? Very good. What is this paraparesis? What is this paraparesis? Yes, the answer is right. Lower motor neuron disease. What do you mean by the word paraparesis? Yes, weakness. But of which region? Weakness of both the lower limbs. Okay, so this is known as paraparesis. Both the lower limbs, right? Weakness of both the lower limbs, and again muscular atrophy. Yes, this is also known as flaccid, absent DTR, no Babinski sign. This is all element disease. Okay, so this is enough for today's lecture. Spasticity is upper motor. Spasticity is upper. There's nothing to do with lower motor. Like what you will get in upper motor is what you will get in upper motor. One thing is spasticity. Then what we will get? Just few more words, and then say thank you. I'm still continuing. Just few more words for upper motor neuron. So spasticity we will get. Then deep tendon reflexes are, you say, brisk or exaggerated. Okay? So the moment you tap the the moment you tap the ligamentum patelli, there is brisk tension of the knee joint. Then there is ankle clonus. You can find yes, tone is high, so call it hypertonia. And we can see a positive Babinski sign in which there is fanning of toes when we stroke the sole of the patient. So this is all for upper motor. And whenever you have to think of lower motor neuron, always think a case of polio. Always think of case of polio, and you will get all the features lower motor neuron paralysis. Okay, so with these words, I seek your permission. We will meet again for next session. Thank you. Thank you very much for all your cooperation. God bless. Bye-bye.